This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe.
Ocular surface disease. It's complex, chronic, and progressive, but rife with opportunity for the enterprising optometrist.
The mission of this podcast is to make this condition more understandable and accessible to those interested in specializing in it. So let's get to the point.
Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I am joined by my co-host Leslie Odell. And we are here today to talk about our glaucoma patients and the potential OSD complications of their glaucoma medications. To better educate us on this topic, we brought in everyone's favorite Midwesterner, Dr. Justin Schweitzer. Dr. Schweitzer is an adjunct clinical professor at ICO and Kentucky College of Optometry. Dr. Schweitzer is a national leader in glaucoma, anterior segment surgery, and anterior segment pathology who lectures to his colleagues nationwide. He is a member of several industry organizations, has held many leadership positions within them, and is the current president of the South Dakota Optometric Society and is involved in community eye care initiatives. He currently serves as chief medical editor for Modern Optometry and is the optometric externship director for ICO Advanced Thompson Vision. That was a very abbreviated bio, but there's so much more to say about you. Welcome, Justin. Thanks for joining us.
Oh, great. Well, thanks so much for having me. Honored to be here. Excited to have this discussion with the two of you.
So we wanted to really just, pick your brain because we know, how much you do in the space with glaucoma management, now with MIGS, and then also just your efforts in preserving ocular surface for your surgical patients, even as they go into cataract surgery. So we thought, who better to bring on, than you. So we're really excited to hear what you have to say. Just a little bit of background for myself too is, my career kind of started heavy in glaucoma. I worked for a surgeon that was doing a lot of refractive cataract surgery. So quickly, I learned a lot about dry eye in a short amount of time. And then what's been really exciting over the past several years is actually to see glaucoma specialists, both optometric and ophthalmology specialists, embracing the ocular surface and taking a proactive approach in preserving the ocular surface for those patients. So, tell us a little bit about, you and also, how you view the ocular surface when you're challenged by this chronic disease of glaucoma.
Yeah, so in my practice, I'm in a tertiary care center. Everything that really comes into me, I always say, is they're really not my patients. I work with colleagues in the community. A lot of times they're either, seeking another opinion about the glaucoma that we're dealing with, or it's surgical cases. A lot of it's surgical cases, preparing patients for minimally invasive glaucoma procedures, other types of glaucoma procedures. And I would argue, and I believe that, I think right now, if you think about glaucoma and the ocular surface, and I agree, there's a lot of discussion around it, and it's good. It's a good thing that this is happening. That most of our glaucoma patients, their quality of life is not being affected necessarily by that small nasal step they have or the small visual field defect they have, but it's being affected by, the ocular surface and what they're putting in their eyes. And by no means do I want to sit here and be hard on drops, because drops, I utilize them every single day. They're a very important piece of what we do. But there's definitely a quality of life issue involved with glaucoma on the ocular surface. Very rarely do you have patients come in and complain about their vision due to glaucoma. They come in complaining because of the way that their eyes feel. And so if there's a way to minimize medication burden, not rid people of them, but minimize it, then I think that's got to be the mindset that we have.
What are some of your first steps? So let's say that you have a patient with a lot of OSD that is a glaucoma patient. Are you still leaning towards a drop as maybe a first line therapy, or do you think SLT? Like, what's your thought process in those cases?
So I think it depends a little bit about what they're on and how many medications they're on. For me, if they come in and it's someone that, is having some issues, or I identify some issues with their ocular surface, and I believe that's part of it, the goal is, how do I minimize that? I think you're spot on with that. I think SLT is a great option. So I'll offer that to them. We have an option to do SLT, maybe minimize some of the medications they're on. I've really loved in that patient population, considering glaucoma drug delivery now. We have one on the market called Bimatoprost SR, and I think of it like a drop holiday with this particular technology. It's not going to be probably a long-term thing for them right now, as indication for it is only a one-time use, but it's a small pellet that we can put inside the eye. It's delivering a medication. I know the patient's getting it, and then I could take them off of maybe a medication or two and then attack the ocular surface with whatever I need to, whether it be immunomodulators, whether it be some MGD treatment, whether it be some topical corticosteroid. But I call it a drop holiday. So they get a break from that medication for maybe 6 months, maybe a year, and just a pause to be able to get the ocular surface prepared, ready to go, and to then come back afterwards with something else. And we may go to something that's preservative free. We may go to something that's BAK free, but very likely they're still going to need something. But I think those are two different scenarios that I really think about SLT, glaucoma drug delivery, on those initially diagnosed patients that are maybe struggling with topical therapy.
So with Durista, I feel like I was sometimes struggling a little bit for patients that were monotherapy with MGD in particular, because we know there is a correlation between PGA plus BAK with meibomian gland dysfunction. So with the introduction of Durista, for me, it's been a great way to do exactly as you said, give the patient a drop holiday while I can focus on gland health. And then, after that pause and we hopefully improve gland quality and function, we can reintroduce medications and keep a close eye on, if that's going to continue to be an issue for the patient.
Yeah, it's really been a nice arsenal in the toolbox now that we didn't have before. And I'm a big fan of SLT. I'm also a big fan of thinking about some of the medications out there that we have some preservative-free options that could be compounded. Imprimis Pharmaceuticals does that. We have BAK-free drops as well now, with Sun Pharmaceutical having a BAK-free latanoprost. And I think we also have well-tolerated prostaglandins. 4 years ago, there was the launch of, latanoprostine Bunad, which is called Vyzulta, which, is a very well-tolerated prostaglandin once a day, that when you look at its safety profile, really only about 6% of patients get, ocular or conjunctival hyperemia from it. So I do think we have a lot of different medications that we still can consider for our patients from a topical standpoint. But I'm still a fan of SLT drug delivery, and obviously I'm a big fan of minimally invasive glaucoma procedures as well to reduce that burden.
So I've been hearing a lot about the compounded medication. Tell me what's available there, and how easy is it for doctors to get that option through Impress?
Yeah, really easy to get. I mean, it's just a simple form that you fill out. You place the order, you contact that company. You can get a variety of different combinations of agents. There'll be some combinations of a prostaglandin beta blocker. You can get a combination of a beta blocker, CAI, prostaglandin. You can get all these different real combinations that they have available. They're all preservative free. And, you dose them typically, if it's just the prostaglandin, you would do it once a day. The combination agents, a lot of times you're doing it twice a day. And I will not sit here and say that's my go-to first line therapy for patients. But when I think about it, these patients that are having ocular surface disease issues. I still want therapy. I still want IOP lowering effects. And it's just an outside the box thought for your patients that maybe need a break from those preservatives. And you still get some efficacy, and really good efficacy from these in my clinical experience with them.
This is a good example, actually. So I'm in Massachusetts, and up until recently, we did not have any privileges to treat glaucoma in this state. So the practice that I had joined had and still really does, has very few glaucoma patients. But this is a good point is in terms of growing a practice. I mean, if you can even work with glaucoma specialists, because, do you feel like that? You're a little bit different, Justin, because you're in this tertiary clinical setting, but do you feel that something glaucoma specialists are very aware of the ocular surface? I sometimes feel like they might want to blow past the ocular surface and just kind of get into the nerve and see what's going on there. But, there's certainly, they're going to hear about it from their patients if they're upset. And even if you are an OD that doesn't have a lot of glaucoma patients, you could even, sort of collaborate with a glaucoma specialist to say, I can help your ocular surface disease patients.
I think that's a great point. You're able to, kind of build your practice through that piece, because there's really probably not a glaucoma patient that doesn't have some sort of at least mild dry eye or ocular surface disease. And I don't want to say that they overlook it, but I think if you look at the sheer numbers, that optometrists have really embraced treating of the ocular surface. And I'm basing that off of just prescriptions written, correct? And to be fair, ophthalmologists, they're in the operating room a lot. They have a lot to focus on from a surgical standpoint. And I do think that optometrists have embraced treating the ocular surface more so than what ophthalmologists have. And that's not, to say that there's not some focusing on it. I just think when you look at, again, the sheer numbers, we're embracing that. I also think that we as optometrists, need to remember that we're the primary care providers for these patients. A lot of these patients are with us the majority of the time. And so for me, for example, if I have a patient that's come in that is referred in from a colleague, an optometrist in our community, I'm going to see them, maybe once, maybe twice, and maybe they just started a medication. Well, if they just started a medication and I'm there for a second opinion, I'm not going to see any ocular surface issues most likely. They've only been on the medication for 6 months, a year, and that patient's going to go back to my colleague in the community. We're the ones, the optometrists that are in the trenches, that are seeing these patients that have been on medications for 5, 6, 10, 20 years. And that's really where the ocular surface disease from glaucoma starts to really present itself. And so we just have to be prepared to manage that. And we're going to see it a lot more often, in my mind, than what our counterparts in ophthalmology are going to see it.
Yeah, I totally agree there. I think, I mean, I'm just thinking about this from my practice standpoint, but I'm thinking, oh gosh, this would be a great practice builder to sort of reach out to these glaucoma surgeons who are maybe not as into treating ocular surface disease. But you're right, and I think that's another thought I had when you were talking about this is you almost, yes, you're referring a patient out, but you really are the person that's managing the whole case, and even if you're doing a referral, like just because you refer doesn't mean that someone else is monitoring their ocular surface. So,
well, I think just from my time working in an integrated practice, I sometimes felt that we were the dumping ground of all the problems, even though, maybe a patient was getting sent in for cataract surgery. There were lots of other things that then we were expected to sort of manage. And I think, becoming the gatekeeper for your patients is going to elevate our profession and also help alleviate some of the strain that our surgical partners are feeling. But I do think it's a great way to, introduce yourself, Jackie, to your glaucoma specialist, especially because now you do have the ability to treat in your state. And then also say, I can not only manage when things, I can not only manage when things are not surgical, but I can also help optimize the ocular surface to keep patients adherent to medications. I mean, that's a big reason why, right, these patients fall off drug use, is because they're not used to a medication that they're taking hurting or making their eye red. And so naturally, once you start that, they think immediately they're allergic or something's wrong. And they come in and say either they don't want to take it anymore, or sometimes they'll come back and say, I stopped it because my eye is red. So just being able to do that, I think will really help grow your practice now that you can focus on glaucoma. I think not only the preservative systems, but even when you're choosing your active meds, right? Timolol being a beta blocker, when we're looking at beta blockers, we can actually decrease aqueous production for patients. So maybe not a great fit on somebody that's already got a low tear meniscus height, or somebody that you're thinking is already an aqueous deficient type of dry eye. Thinking about monotherapy, and now you're absolutely right. We've got so many great options with alternate preservatives, preservative free. And it's exciting to see SLT come into the fold as recommended as a first line therapy. So a lot of times I'll start a patient, I'll kind of see how they're doing with a drop, and then quickly introduce the idea of something that's a drop alternative. What about, Justin, when you're kind of in that mild to moderate patient? A lot has changed with this minimally invasive glaucoma surgery, and I know you do a lot of that co-management in your practice. and I know we can get some drop reduction there. So maybe just tell us a little bit about how that landscape's changed, especially as it pertains to our cataract patients versus standalone, not needing cataract surgery.
Yeah, no, I think minimally invasive glaucoma surgery is definitely an option for a variety of different reasons. And I think the new mindset, and it's a mindset that's been around for a bit, is this interventional glaucoma mindset. And that terminology or that term can be kind of looked at in a variety of different ways. Number one, interventional, meaning intervening earlier in the disease process. So our mild to moderate glaucoma patients, not allowing patients to go from mild to moderate all the way to severe. We have safer surgical options, and that's really MIGS. But the other way that I think of interventional glaucoma is intervening when there's quality of life issues or ocular surface disease issues, or patients are suffering from maybe taking too many topical medications. And I think something to comment on before I jump in that is it is a matter of how many medications patients are taking typically. I mean, patients that are on one medication, a lot of times will do pretty well, not only from a compliance standpoint, but from a comfort standpoint. It's when you start piggybacking meds upon meds upon meds. So, in my practice now, I kind of think of maximal medical therapy as just two medications. We have enough different medications out there that it's very rare we need to go beyond two. And if we need to go beyond two, I like to start thinking about MIGS procedures or SLT or things like that. And I use SLT as a standalone first line agent as well. I just think gone are the days, or should be gone are the days, that we're throwing patients on three medications unless there's someone that already has advanced disease, that already is exhausted a lot of other options that are out there. So when I think of MIGS, cataract surgery in mild to moderate glaucoma, if a patient is being referred to a cataract surgeon and they have glaucoma, they should be getting a MIGS procedure in combination with it. The data supports it. We're not adding any risk to the cataract procedure by making that recommendation, and that should be done. In the standalone world, and I think this is really what what this is about and what your question's about is, say you have a patient that is not progressing, but they come in and they're on multiple medications and they're complaining because their friends are complaining to them how their eyes are red, or they're complaining because when they put the drop in, it burns or it irritates them. That's a situation where, number one, very likely that patient is going to be eventually progressing, because we have studies and data that shows that patients with side effects versus no side effects from their topical medications progress much more rapidly. And so it's always a tougher decision to recommend an inside the eye surgery for a patient when they're not progressing. But we really have to consider it when there's a quality of life issue happening. And we have a lot of good standalone procedures that we could consider. And we know from all these studies as well that by doing one of these MIGS procedures, we are going to reduce the medication burden. It may not be taking patients that are on three medications to zero, but a lot of times we could take patients that are on one medication to zero or two medications to one. And that's only going to improve compliance, and it's only going to improve the ocular surface as well.
I saw some really interesting statistics around this, that when we're thinking about MIGS in just our cataract patients with glaucoma, that we're only really reaching about 15% of our patients that have that possibility. But when you see what's available in that standalone space, when your patient doesn't need to be having cataract surgery in combination, it really opens it to about 85% of patients that we now can be looking at as a possibility. So definitely MIGS are the future of our surgical management, no doubt. We've seen that growth even over the past several years. So that's, exciting just to see what impact that's going to have on our patients, for sure.
Well, we know that there's not a lot of quality of life studies out there, but I'll share with you, I did a very small pilot study, and I don't think this is going to blow anyone's mind on this study, but, we did a study, a colleague of mine, Dr. Whitney Hauser, who you guys obviously know very well, and in our practice. So it was a 2-center practice. And all we wanted to do was see, what if we did a MIGS procedure in combination with cataract surgery? How did that affect patients' quality of life? And so we had them take an OSDI before the surgery, and their OSDI was 40.1. There were about 50 patients in this study. So that's the severe level on the OSDI. 33 to 100 is severe. They underwent cataract surgery plus a MIGS procedure. At 3 months, we had them retake that OSDI. And we also looked at conjunctival and corneal staining. We looked at hyperemia. We looked at tear breakup time. What we found out was that the OSDI went down to 17.1. So not normal, but a lot better and almost normal. We saw a 49% increase in their tear breakup time. We saw a significant reduction in conjunctival and corneal staining. And we also saw a significant reduction in conjunctival hyperemia. And to no one's surprise, their medication burden went from 1.5 medications down to 0.5. And very likely, that's why we saw all the improvement in this particular study. Now, a short study, only 3 months. I would love for someone to do a 2-year, 5-year, 10-year study doing the same thing to see if those quality of life issues maintain over an extended period of time. But even in 3 months, it did tell us a lot that MIGS can help with quality of life issues on top of helping the ocular surface.
That is awesome. And there you go, Jackie. You just said, what should we be doing research on? He just gave you your project for the next couple of years.
Yeah, there it is. In terms of, I was just Googling this because I couldn't remember, but Eyenovia is a company that is working on really a different sort of eye dropper. Have you seen this? Have you guys seen this? I thought that they were working on something for a glaucoma medication. Maybe Justin, you know this better than I, but that's another sort of interesting different drop delivery in terms of lessening the toxicity of the drop. So it's a micro-sized eye drop that sort of is like almost like a spray on the cornea and dissipates kind of on the cornea. But the drop amount is significantly lower than a normal drop bottle. So I think that the story is heard that people are having corneal toxicity, and even a standard eye drop bottle is really old school now. Like that hasn't been updated for a long time. So Eyenovia is a company that's working on that, which I think is kind of cool. Do they have something for glaucoma, Justin? Am I right about that?
Yeah, you're exactly right. It's a microdose latanoprost that, the advantages of it, like you described it, it's preservative free. It's a small amount of medication. I think that's the beauty of glaucoma drug delivery in general. And it's something I'm very excited about. You have intracanalicular plugs that are being looked at that releases preservative free drug. You have the inside the eye things we already talked about, Manoprost SR. You have a variety of different types of glaucoma drug delivery that's coming. It's a huge market. But a lot of it is small amounts of medication, as you mentioned, and a lot of it's preservative free. And so that's going to be super helpful for the ocular surface, but also from a compliance standpoint with these types of delivery systems.
Brings up one other thing about drop size, which is nano dropper.
But there was an article probably a year or two ago that was even like mainstream media on this eyedropper size. This was like, I read it in NPR, but it was talking from a cost perspective was this like people are just wasting away like all of these really expensive drops. But, so people have heard.
With nano dropper, you can attach that to any of the glaucoma bottles that your patient's on, and it gives them basically a microdose, which is all they need, and really saves some of the adnexa changes that you see. If you watch a patient put drops in, sometimes they flood the eye. It's all over the skin around the eye, and they might not wipe off that, which it's not intended to be on the skin around the eye. So sometimes redness or physical changes that we see to the surrounding tissue, we might be making better just by eliminating that overflow.
It's a great technology. I'm utilizing it in our practice. It's been really nice for patients that maybe you really want to keep someone on this specific branded medication. Their insurance may not be covering it, whatever it may be. It's been really nice. It preserves a little bit more of the bottle, but you'll be seeing shortly, and my understanding is that American Academy of Optometry, they're going to be presenting some data around, efficacy, which they already have a little of that already, showing that you're not losing efficacy. They're going to present more of that. And they're also going to be probably, and I believe I'm understanding this correctly, some data around the ocular surface and how it can help in that regard as well.
That's a good, I was actually going to ask you that, Justin, because when I first brought this up to a glaucoma specialist, he was like, yeah, but like, is there any studies that this is actually going to work as good as what like all the studies are on a regular bottle size, dropper size. And so I know there was some concern initially. So that's interesting. There's going to be some study coming out about that. It's great.
It's a fair question. And it's a question I think we've all asked and want to know. And they do have a small study right now that you can find, but there's more coming is my understanding, which I think is important.
Justin, thanks so much for joining us. This was great. Thanks for taking the time with us today.
Oh, it was a great time. Thanks for having me.
And now for the To The Point wrap-up. We've learned from TFAS News 2 that iatrogenic dry eye is a big concern when we're treating our dry eye patients. This comes in many forms, surgically induced and also topical medications. Something for us to think about when we're seeing our patients with glaucoma is their chronic use of medications. We've learned from this episode ways to help identify ocular surface disease in our glaucoma patients, as well as ways to help treat the ocular surface a little better by changing out preservative systems, changing out active ingredients, or rethinking glaucoma altogether and pushing for interventional management of the disease with things like MIGS and SLT. Just remember, when we're treating glaucoma, the ocular surface is under attack, and you want to work hard to preserve that. In turn, hopefully your patients will have improved outcomes.